Hello, everyone, and welcome to the CQII monthly National Quality Improvement Technical Assistance Call titled Selecting Performance Measures for Your Quality Improvement Efforts. The presentation will be delivered by Martha Cameron, MPH, Public Health Specialist, Georgetown University, the DC Center for AIDS Research, and consultant and coach at the Center for Quality Improvement and Innovation, CQII. Martha is originally from Zambia, Africa, where she was born and raised. Martha has been serving in several leadership and executive roles for different HIV policy and advocacy organizations, including the International Community of Women Living with HIV North America, National Working Positive Coalition, and People Living with HIV Caucus. Previously, Martha worked as a director of prevention for Women's Collective in Washington, D.C., and as the executive director for Every Orphan's Hope, or EOH, Incorporated, an international faith-based not-for-profit located in Zambia. Martha has a bachelor's degree in education and a master's degree in public health. A few reminders before we get started. This call is being recorded and all lines have been muted. Please do not unmute yourself. If you are on the phone, please do not put us on hold. At the end of the hour, there will be time for questions and answers, at which time I will ask those who have questions to unmute themselves. If you are on your phone, please unmute by pressing #6. Feel free to use the chat room to ask questions and offer comments. Martha, we are looking forward to your presentation.
All right. I hope everybody can hear me. The horrible thing about webinars is that, I can't see everybody, but I hope you can all hear me. Okay. So as Daniela said, we're going to be talking about performance measures. And I come at this work, not from a data perspective. I'm not a biostatistician or by any means. I've worked in HIV for a long time, but at some point I realized I really had to understand and love data in order to work in HIV and to make improvements. So that's a perspective I'm going to talk about it today, and I'm really excited to share. Our learning objectives include just understanding the definition of quality improvement broadly. Some of you may already be familiar with quality improvement. I know a lot of you work for Ryan White clinics. And so we'll review that very quickly. We'll go through the QI and quality improvement guiding principles that some of you, if you've been part of collaboratives or other quality improvement forums, may be familiar with. So I'm going to zip through those. And then we're going to explore the concept of an indicator, right, which just forms the foundation of a performance measure. You've got to do a calculation and you'll have the resultant indicator that tells you which direction your measurement is going, essentially. Those two words sometimes are used interchangeably. I might do that. I don't want you to get confused. The idea is we're looking at that performance measurement. And then we want to gain a basic understanding of the percentage and rate calculations because, that's essentially how we get to the performance measurement. So we will do a bit of fun calculation, and hopefully you will all participate with me in the chat, and we can all get calculations wrong. But I think I saw somebody on here. I think I saw Steve, and he will make sure he corrects us. We can also, we'll then look at the actual process of selecting a performance measure using the Health Resource and Services Administration, that's HRSA, and HIV/AIDS Bureau, HAB data, or their performance measures, because they have created standards based on, that are evidence-based, based on 40 years of the HIV epidemic. And so that's what we go by. And so we'll kind of use that as a guiding principle. And then we're going to briefly look at the PDSA, so the Plan, Do, Study Act, which is a simple method of improvement in healthcare. I think even personally in my life. I learned this about 10 years ago when I first was part of the then National Quality Center, now CQII. And you can use it in your personal life, but, we'll look at it in the context of when we select this performance measure, how do we improvement? And it's a simple method of improvement. You can find it online, and as well as you can find many other methods of improvement that you can use. The key is just keeping it real simple. Expectations. I know there's a lot of us. If from these objectives that I have shared, I'm not maybe really meeting something you were thinking about learning about today, please go ahead and put it in the chat and, just let me know, hey, I was also kind of expecting to understand this or to learn about this. And, we can check in towards the end and see if it's not covered or not. But I know that we came in expecting to learn about that performance measure in its simplest form, and hopefully that's what I'll deliver today. And if I can do it, then I really do believe everyone on here can. So thinking about how did we get here and the roads that we've taken, right? How do we measure HIV and how does that influence funding of HIV care? We know that HRSA and the HIV/AIDS Bureau is responsible for distributing a lot, millions of dollars to many different institutions and hospitals across the country. And so they've got to have a way of doing that, right? Of measuring how much is given to which location. And so, they had to come up with something, and this is what we're looking at. Some of you may already work in data. But then most importantly, how do we use then that data to make decisions or to select what is being measured? Now, for HIV clinics, there's specific measures, and we'll take a peek at those that are specifically required of especially Ryan White organizations to measure. But you might, wake up one day and say, I'm seeing this problem in my clinic, or I'm seeing this issue among my patients. And how do I convince people that we have a problem? And most importantly, how do I then measure that so that if people do agree we do have a problem, how do we measure that, get some funding for it, and then show that we have made an improvement? I think that's something I struggled with before, and hopefully this can help. And then how do we use those results to make the decision about the care that is being provided? And so that's where we're at. In its simplest form, quality improvement is really about balancing that performance measurement and the quality improvement activities. You can be doing so much at a clinic. You can have an amazing clinic with amazing staff and amazing people, but the services that are being provided maybe are not really reflecting the needs of your population. Or maybe even with the most amazing services that you have, somehow the viral suppression rates, which is, an important indicator of HIV care, is not improving. So then what is it? And I think quality improvement is about balancing that, that our quality management program, if we have it, actually supports those improvement activities. Some of your organizations or institutions may already have like quality improvement teams. Sometimes those are loosely formed, like you do have a data person and they just communicate with your director or your development person. It's so different in different places. But the idea, honestly, that I've learned over the past 10 years being part of CQI is that everybody should at the clinic, touching a client, should be able to have some idea of what is going on at their clinic and what role they can play or what role they are already playing to make that improvement of the services that are being given to the patients. Whenever we do sort of an expanded training on quality improvement, we have some really fun pictures that show these principles and sort of just, make you reflect and think about it. But I am zipping through these quality improvement principles. And the first one is so basic, but so important, right? Success is achieved by meeting the needs of those who are served. Like I was saying, you can have amazing things, and by all intents and purposes, your clinic or your hospital might be the best in a certain location, but if the needs of the people that you're serving are not being met, then you most likely have not succeeded. This is, for me, the most important one that has been a lesson, again, over the years. Are the problems, usually problems are not found in the people. It's not the people, it's not the case manager, it's not the front desk person, it's not because the doctor is busy, it's because there's something wrong with the process. There's a break in the process, so there's something that is happening that is not making the people who are working on it effective. And so I've loved this because it has taken the pressure off of, oh, it's just because the front desk person is so slow, or the nurse is not doing this or that. And if you drill down, you find that the problems are usually in the processes and not the people. The great thing about quality improvement, we never have to reinvent the wheel. Somebody else has had that problem and they'll have a solution for it. They'll have a best practice for it. So, usually with quality improvement, especially after so many years, we never have to reinvent anything. We can learn from best practices of other people. And then something really important that you all might know already as well is that we're going to achieve this improvement in small incremental changes. We've heard that Rome wasn't built overnight, et cetera, et cetera. It's making that one small change, doing something by next Tuesday, and not overwhelming ourselves with this great, big, incredible plan for change that then falls apart. Small incremental changes. And key, of course, to all of this is that everything that we do is based on accurate and then measured data. I learned the phrase about garbage in, garbage out, actually, through all this work. And so it's important that you have the correct number, the correct baseline to start with. Otherwise, then, we're going to make a mistake throughout the process. A step backward, 2 steps back after you've taken 10 steps forwards is not a mistake. We're going to start small. We're going to grow, even though we're thinking really big. We want to make an amazing change at the clinic. We want to get people housed. A good part of our population is unhoused. We want to get people housed, but we're going to start small and think, what can we do? We're going to set priorities and communicate those clearly. We want everybody to know right now we're working on this small group of people that have a substance use issue. And before we deal with a housing crisis, and before we deal with this crisis, or no, we have had a number of people falling back in their viral suppression. What is it? Is it the medication? Is it something that is going on? We're going to set a priority and we're going to communicate it clearly. And then, the community, the patients, the clients are always first. So what is this performance measurement? Why do we measure HIV care? I was talking about priorities a second ago because it does communicate what the priority is, what is going on that we need to take care of right now in our patient population. And then once we have identified that, we are driven to improve it. I have been part of a few collaboratives as I've worked, with CQI, and most of them have been centered, at least quite a few that I've worked on have been centered around viral load suppression. But attached to viral load suppression are many things. If you haven't taken care of some basic, what we call social determinants of health, you're not going to achieve viral suppression. So what is that one small thing you can do? But it's always driving to the fact that you want to improve something. I love saying that it separates what you think is happening from what is really happening. Oh, I have seen these 3 clients having this crisis. We must have a problem in the whole city. no, that is not what is really happening, because when we have collected the data, this is what is actually showing. And we can do that by establishing that baseline, right? We have found out that it's only 10 people that are actually unhoused out of the 100 people that we have. And for the others, it was only because of COVID, and then this happened, and now that has been rectified, and so on. But we're going to continuously monitor it and help identify other problems as they emerge when we're monitoring that specific thing. And then measurement also allows for comparison across jurisdictions or networks. Now, that's actually pretty wide. The collaboratives that I've been a part of, for example, actually can compare just across clinics. Clinics in the area begin to share data and realize that they can compare notes about what is going on. HRSA or HAB has an amazing website called Campus, and if we have time, I will show it very briefly at the end, but it actually has data that it collects from Ryan White jurisdictions, and you can actually see and compare across the board. But for our purposes, it's always good to know the data at your clinic. And sometimes if you're working as part of a Ryan White Planning Council, for example, or as part of a collaborative, you could find that it's possible to measure across a network or across a jurisdiction. But the bottom line is the Ryan White legislation does emphasize quality management, and it requires that we measure that improvement. Otherwise, what would they be spending all this money on? So wanted to make this differentiation. And I know this might be basic for some of you, but I hope you came so that we can get this collective knowledge. Measures, they indicate an organization's performance, right? So it's aggregated. It's a macro view. And the standards of care or service standards, and some of you on the call may be case managers, you have this outline of expectations of care. The standards of care actually set also by Ryan White. There's certain things that they expect, that if you're a case manager, you're going to be monitoring somebody's medical visits, you're going to be monitoring their viral load, you're going to be collecting certain information on referrals that they must get, and so on and so forth. And so you are managing that. You are checking off, have I done this and that and this, as it relates to a certain clients or a group of clients at your clinic. But the measures will be looking at sort of an aggregate view of your organization's performance, and not specifically about the standards of care. So what is this indicator? And like I said before, we sometimes use indicator and performance measure interchangeably. I grabbed this from a website that is also associated with HRSA. They are standardized, evidence-based measures of healthcare quality that can be used with readily available data. And of course, it tracks clinical performance and outcomes of an institution or a client. So it's evidence-based, it's standardized, and we're going to see the standards that are required by HRSA. But they're indicators, right? So if you're driving your car and you're going to turn right, you're going to click on your little indicator so that others can see which direction you're going. And to me, that is the simplest sort of visualization of it, right? That when you have a performance measure and you actually measure it and have a number, that is going to indicate, are you above a certain standard or below a certain standard? Are you going in a good direction, or are you going in a not so great direction? And do you need to do something about it? I think these slides are shared afterwards on the Target HIV website, so the link will be there. You could also just Google, Ryan White performance measures portfolio, whatever, and you will find them. There are different kinds for different things. I just picked out 3 that will illustrate kind of what we're doing here. And so as the aspect of care as it relates to art, people living with HIV are supposed to take antiretroviral therapy. And so how do we know that they're taking the antiretroviral therapy as they're supposed to? Well, we're going to know that they picked up a prescription. So we're going to be measuring that. We're going to be checking on that. And then we're going to know by their viral load suppression numbers that they are actually on ART and they're, because they're suppressed. Are people retained in care? Well, we're going to see, are they getting their medical visits or the reverse, right? Is there a gap in those medical visits that would show that maybe they're not retained in care? A little while ago, some of you may be familiar with sort of the cascade that came out, or now it's called the continuum of care. And it shows that, how many people living with HIV, how many people got tested, or how many people are actually connected to care, how many people are actually on on ART, how many people are virally suppressed, et cetera, et cetera. It's expressed in many different ways, but it's essentially trying to show some of these measures that are done as it relates to somebody who is in treatment or who is on in a clinic that is funded by Ryan White. They used to, and I'm sure they still do, check on opportunistic infections. I'm sure very early on in the epidemic, these were a lot more, PCP, so that was the pneumonia, Kaposi sarcoma. I mean, there are all these opportunistic infections that people would get if they ended up with AIDS, with an AIDS diagnosis. And so they would check that, and that would be an indicator of people were getting into care or getting care. But this is just an example. You can take a look at them. And we're going to, talk about, you might want to have your own indicator about something. So at least we'll kind of have a little bit of a standard as to how you can maybe come about that performance measure. But what makes a good one, right? It must be relevant. You do not want to collect information on how many people are taking COVID vaccinations, for example, if it's not relevant to HIV care. At some point, maybe later on, you might think, oh my gosh, a lot of our populations got COVID. And so that's something you might want to measure as an aside. But is it really relevant to the care that you're giving at a certain point? Are you responsible for giving COVID vaccinations and COVID care under the Ryan White funding that you have? Maybe, maybe not, but we want to make sure that whatever you're measuring is relevant. And does it have an impact on the programs or your clients? Of course, the ones that have been suggested by HRSA are relevant. We know that they are. But I think sometimes, especially now, as people are aging with HIV, for example, and experiencing a lot of other things that impact their quality of life, it might be good, to think about something else that you want to measure that might require funding from HRSA or support from HRSA. And so, but as you're doing that, you're thinking about what impact does this have on my clients right now, and is it relevant? And then, of course, it's the measurability, right? Is it really realistic to measure this and get it efficiently measured? I always give an example. I'm, basically live around the DMV. Housing in DC is a huge problem. We have a ton of gentrification going on. And even before that, it was, before that, and then there was COVID as well. And then, of course, the housing market has amplified that quite a bit. But housing was generally a problem. So we know that that's an issue for people living with HIV. But is it something that you can really improve, especially if you wanted to do an improvement project in 6 months or even in a year? Is it realistic to think that you can actually really make a change specifically in housing? Of course, you're going to be working on it and referring people to HOPWA and other services that might be there. But sometimes when we're working or picking a performance measure, we want to make sure that it's something that can have that can be measured realistically within the context of what you're trying to do. It might be difficult to show an improvement because housing is just such a hard thing to deal with. It doesn't mean you're not working on it. I just encourage people to pick on something that is something that you can actually do something about. Thanks. I'm seeing the comments in the chat. Continuing accuracy. So is the indicator based on accepted guidelines or developed through a formal group decision-making process? I think, Daniela mentioned I worked for a women's organization that was a non-medical case management. And we were trying to get people to have certain screenings. And so some of the case managers suggested maybe we could do pedicures, give the women pedicures. A long time ago, they actually used to give massages and stuff, but they, definitely cut that out. But, pedicures, bring the people in for pedicures so that they can get these screenings done. How are you, was that acceptable? Can we make a group decision about this? Is it really worth spending that amount of money or maybe getting a donation to really get an improvement on those screenings that you need for women? And then can it really be improved? Can it be expanded? Or are there limitations of services or population? So all those things are things that you're going to need to discuss. I just gave the pedicures as an example because I need one. And heck, if they were saying I could go get a certain screening and get a pedicure, I might go for that. But I'm not sure I'd manage to convince my whole clinic team to do that with me. Okay, so we're going to do a little bit of calculation. I ask that just like I'm about to do, because I'm not going to pretend I'm going to do this in my head, just have a calculator next to you so that we can at least do this together. Just, let's do some grade calculations here, back to grade school for a second so that we can really dive into what we're doing. We'll do a percentage and then we'll talk about the rate and then we'll talk about how it might apply to the performance measure. What is a percent? What is the percentage? So we know that it's 1 part in 100 and that it's an amount that is equal to 100 of something, right? You have 10 children. You've been busy pre and post COVID. And 3 of those children have pneumonia, unfortunately, because the weather has been cold. What percentage of your population, of your children, has pneumonia? I would love to see it in the chat so that I know you're all tracking with me. But we know that will be 30, yay, 30%. So we can do that calculation, right? Okay. I am going to show you a little bit of data. No, that's not right. No. Little bit of data here, and let's see from this data what percentage of these patients, my patients in my clinic, reached viral load suppression. Because that was easy. 30% was easy. So we have 5,681 people that achieved viral suppression. And in the clinic, there's actually a total of, well, that's not what that data is saying, but we'll use that as an example. Just say 6,630. We were measuring from 6,634 people. Out of the 6,634 people, 5,681 achieved viral suppression. Oh, there you go, Amanda. Yep. So we had the numerator, that's the patients who are virally suppressed, with the denominator, that's the patient who should have been virally suppressed, and we'll get into that in a second, will give us that number, and then of course we multiply that by 100. And here you all got it. Somebody got 85 point something percent, 86. Yeah, 86% of that specific total population achieved viral suppression. So we got that. But is that, we'll talk about the performance measure in a second. We know that it's not that simple, right? But at least we can do that math. But there's a different way that they want you to count that when you come to doing your performance measure. However, I did want to talk about like a prevalence rate and ratio, and how it might be that I, Martha, have 500 people in my city that have an opioid crisis. And then Daniela over there in New York has 500 people that are also having an opioid crisis. And so we all run to HRSA and say, hey, HRSA, we have 500 people in my little rural city that have an opioid crisis. All of them are living with HIV. I need help. And Daniela, who lives in New York, does the same thing. So how is HRSA going to think about how much money they give me? Are they just going to give Martha from a little rural city 100,000 to deal with that population, and then Daniela too from New York to deal with the same population? But that's how you end up using a rate instead of a percentage or a prevalence, which prevalence is usually done like a percentage, to find out, to really be able to understand how many people are in a jurisdiction, simply to show. So I, Martha, in a smaller city, had 500 people. Daniela lives in New York, a big metropolis, and she had 500 people. That 500 people in an opioid, it's going to be a huge impact on my city. Same thing with Daniela. That is going to be a huge impact in my city. But how are we going to accurately compare those two? And so we divide by 100,000. And this has been done, and of course there's different ways that they can do it, but this has just been done in order to standardize a population so that we can compare. And so you will hear people saying, yeah, they have this number of people per 100,000, or sometimes it will be per 1,000, depending on how they're doing it. But 100,000 is the number that they usually use, and you hear them saying, yeah, we have this number of people having this crisis per 100,000. And that would be able to accurately sort of compare using that standard. And I think 100,000, maybe they came up with 100,000 so that you don't end up with like a 0.5 or half of a person, because you can't plan for that. But the bigger the number, at least is able to show how many people per 1,000. So if you have 500 people and there's only what's 500 times 1,000 people in your population, and then Daniela has the same number of people, but there's 1 million people in their population, you're going to do that division, right? You're going to do the 500 over 100,000 for me. You're going to do the 500 over 10 million for Daniela, and then you're going to multiply it by this 100,000 in order to get a rate. And the only reason I shared that, not to complicate things, is that some of us may be coming from places where there's fewer people than other places. So you always want to take, you might want to use a rate in order to be able to effectively compare with a bigger city if you're comparing in terms of performance measures. If I lost people there, I can get back to it. Just put the question in the chat. But I just wanted to show that, we use the rate to standardize, to be able to effectively compare between jurisdictions that are smaller and larger. But hopefully I didn't lose people. I want to be able to note right here, we don't want to let the perfect be the enemy of the good, something that I've learned a lot in doing quality improvement. But with data, you know, you have to go and get it. You have to count it. If you want to do something, you want to measure something, it is something you have to look for. You can look for it in documentation that you might have at a clinic. You can decide to do a survey. However it is that you need to find the data, that you need to do a performance measure, you have to get it. It's not gonna magically appear. You cannot guess and say, oh, I think we have this number of people. Oh, I think. You have to actually look for it and get it as accurately as possible. Sometimes the data that we're looking for, even at our clinic or in our jurisdiction, by the time you get it, it's a little bit old, because usually our data collection lags behind. They don't do this overnight. So jurisdictions sometimes at 2 years, the CDC and HRSA, you find that they're displaying data from like 2 years ago. And so by the time you're thinking, oh my gosh, you're looking at the CDC or the HRSA Hub website or your local health department website, and you're thinking, 20% of people in this city were unhoused, or 20% of my population possibly was unhoused. It was 3 years ago, the data that you might be looking at. And so if you want to do something around housing or around a crisis, you might have to get some real-time data. There is a lot of it. It can be overwhelming, but if you're focused and there's something specific that you want to get, you want to go to accurate sources, especially that are relevant to what you're trying to do. So your clinic, your hospital, your jurisdiction, your planning council, HRSA itself, it has to be interpreted and analyzed. And this is where I love the idea of working with teams, working with the different staff, working with people of lived experience, to help you analyze the same data. Case managers, usually tell stories of how when a client speaks to the front desk person, they had one story. They speak to the case manager, they have a different story. They speak to the doctor, they have a different story, right? And so the case manager might have a different perspective of what they're interpreting the data compared to the front desk person who knows Joe and Jim, maybe from their neighborhood, and know that this is not happening, and know that they're clinic hopping, and know that this is happening in order for them just to get something. All kinds of things, go on. It's usually good to interpret and analyze data from the different perspectives, but the data itself should be the basis of what you're trying to discuss and analyze. It appears to be, it may indicate that it could mean the doctors have, I think weird ways of interpreting data, but we know that if you have a team, if you engage a team, it could be interpreted in many different ways. I always talk about data manipulation because I've been in planning councils when they're trying to get something funded, and all of a sudden the data is just pointing to a certain direction because we need to get that funded. And so it's always good to question context. Yes, I see timing and so on. It's really important. And then of course that it's always changing, right? It was one thing this year, oh, we've never had any, syphilis diagnosis in, DC for a long time, or we have, and especially among people living with HIV, but all of a sudden it's out the roof. And then it's, then it's gone crazy because there was COVID or because something happened. And so it's always changing. So if you're trying to do something around a performance measure, you really want to be monitoring and discussing it as consistently as possible. So like I said, the HAB, HIV/AIDS Bureau, has core performance measures that they use, that clinics are supposed to use, that is the standard. That's the link. And I think towards the end, if I have a second, I'll actually go to the website. I literally did a screenshot of the website. And I wanted to discuss one particular one, which is the viral load suppression. And the reason why, I mean, everybody collects it, and we know that this is not what, for the patient, it's not all about viral load suppression. But we know that it's a good measure of what is going on biomedically with someone. And then I always share with groups and different people that I'm working with that I love to attach a performance measure that I'm doing to viral load suppression. Because one way of showing that you've made an improvement could have to do with viral suppression, especially if it's being maintained or increased in the clinic, or the fact that a certain group of patients are not doing very well in a particular area. So our social determinants of health, right? They're not doing good with their substance use or with their housing, and especially with mental health. And then, of course, there's age now. As people are aging with HIV, they're dealing with different comorbidities and all that. And everybody wants to get on that bandwagon. Everybody wants to understand what is going on with aging and how it's impacting, people living with HIV. And so you could measure that, you could find a measure for that, but I always encourage people then tie it to viral load suppression so that way it presents a case, especially when you're dealing with HRSA, that you're either improving or maintaining, viral load suppression because that is what is key for people living with HIV. They have a better quality of life or better quality of care if their viral load is suppressed. But that does not necessarily mean their quality of life has improved. But the two, I believe, always have to go together. So, yeah, I know HRSA is focused on viral load suppression, but, I think it's important to kind of say, well, if people are not housed, or if their mental health is not great, or actually sometimes mental health might even be great. I mean, viral load might be great, but mental health is not going to be great. And at some point that could impact the other. I think you can have great viral suppression rates, but if the quality of life of people is not the best, sometimes I feel like that's not the biggest success. But still, viral load suppression, very important. So how do they measure? What is their performance measure, right? So their description of the viral load measure is the percentage of patients, regardless of age, with a diagnosis of HIV, obviously, and with a viral suppression load of less than 200 copies that at least had a viral load test in that measurement year. So this viral load suppression rate is not from 2 years ago, it's from that year. They had a medical visit, and they have HIV. Doesn't need to be said. So their numerator, so when we're talking about the percentage thing, the numerator, the top number, is those patients that have a viral load of less than 200 copies in that year. The denominator, which is the bigger number, will be the number of patients, regardless of age, with a diagnosis of HIV with at least one medical visit in a measurement year. And when we did the percentage, we just took the smaller number and the larger number of all the percentage, of all the patients. And whenever I do this training for my groups and people like me, I say there is a specific definition that is going with a denominator that might not include all your patient population. So at first I just said you have 10 kids and 3 of them got pneumonia that year, and it was 30%. What this measure is saying is you have 10 kids, you're only gonna get those ones that went to the doctor. So out of your 10 kids, only 7 of them went to the doctor. Only 7 of them. And of those 7, only 3 of them ended up with pneumonia. So that measure is going to be 3 over 7 and not 3 over your 10 children. And this is critical, and I share this because HRSA and Ryan White has been doing great in terms of taking care of patients, and the viral suppression rates are pretty good. Their standard is 95%, right? Then some clinics are below that, some clinics are close, some maybe even surpass that. But I always remind them that you're not looking at the entire population. You've only taken those patients that had a clinic, a visit, right? A medical visit in that measurement year. If you have 10, let's go with 100, you have 100 patients and only 50 of them managed to get that medical visit in that measurement year, then it means 50% or 50 of your clients haven't been counted in that viral suppression rate. There's 50 people that were not counted because they never had a medical visit, or they never had a medical visit that was counted in that year. And this could happen for any number of reasons, but it means we're only counting those that went to the doctor, and of those, we know if they went to the doctor, they're most likely to have a viral suppression, a viral load of less than or of undetectable, hopefully, especially because they're going to the doctor. But that's going to look good. If we had taken the denominator to be all the clients, regardless of age, with an HIV diagnosis, regardless of medical visits, that viral suppression may not look too good, because some of those may include those that never made their doctor's visits, those that may be having other issues, and they do not have a viral suppression rate. And for me, that is key when you're thinking about how to select your performance measure. We, in DC, as part of our collaborative, we decided to flip this in the clinics that we're working with and say, who were those that did not make that medical visit? And let's look at their viral suppression rate and see if we can do something about that. But I also want to draw your attention to the fact that there could be additional exclusions in that denominator. In this specific one, there's none. But they could then say, well, of the people that at least went to the doctor, maybe only include those that then picked up their prescription after their doctor's visit. Or if maybe, depending on how labs are done, sometimes labs don't get done in the medical visit, maybe exclude those who they had the medical visit but did not get their labs done. So there could be an additional exclusion criteria. Hey, get the ones who made the medical visit, but if they did not pick up their prescription, don't count them in the denominator. Okay, so you have 10 children, 7 of them went to the doctor, only 5 of them picked up their prescription, and 3 of them have pneumonia. You only do the 3 over 5 because now you're excluding those that actually never picked up their prescription. And so, HRSA made this standard because I'm sure at a certain point, different clinics or different jurisdictions maybe were having performance measures that were different, that were including certain people or excluding certain people. I remember there was a big deal one year, maybe about 10 or 15 years ago, when they were looking at Papua numbers. And it turned out that jurisdictions, I think, like New York or San Francisco, places, that where the HIV epidemic had been really, really high, where they were counting people that had died, essentially, of HIV in their HIV numbers, in the numbers. So you were only told to count the number of patients that had HIV. You were not told to exclude anybody that had died, or you were not told to exclude anybody that were no longer on the, on your clinic. And so those numbers were completely expanded until now they said, well, now we're going to exclude people who have died in your performance measure. And that way we can allocate the right amount of money to a certain jurisdiction without counting even people who had died. There's also an issue with AIDS cases, for example. If you're counting people that had AIDS diagnosis, there would be more in certain jurisdictions because a lot of people are now not getting to AIDS. They're getting HIV, but thankfully, if they're red carpeted and get into care, so sometimes they might exclude people with for a specific reason, or they would rather count new HIV diagnosis, which has become really critical because in the South, we're getting more people, more new diagnosis than in other jurisdictions. So that becomes important when you're measuring something to ensure that you're counting a specific, population of people. When choosing a performance measure, say, for instance, in your clinic, you're saying, I think we're having an issue with our youth. And there's a lot going on with them, lots of housing issues, substance use issues, and so on and so forth. And so you might want to say, well, generally, our viral load suppression, when we do it this way, is great, but I would like to count the percentage of patients, not regardless of age. I want them between a certain age group. And that's who I want to be in my denominator. So in your denominator, kind of number of patients who are of this age group with a diagnosis of HIV who have at least one medical visit. Or you might even say, you know what, they're not making their medical visits. So can I just see the number of patients, regardless of age, with an HIV diagnosis that have at some point been in our clinic this year, and then look at their viral suppression rate. And that might end up being very, very different. And so you can do the same thing with mental health, right? We know that our case managers, collect information on mental health. You're thinking there's a mental health crisis. Hey, let's do this population. Let's do this denominator. Let's include with a reference to mental health services or something like that, so that you can be working on a specific group of people that have a specific issue that you are trying to measure. But I think the idea is to be able to use part of this baseline, right? Your patient population obviously have an HIV diagnosis. You're going to have a denominator that addresses your issue. You might have an exclusion criteria to clean that data up a little bit, but you want to include those, and then maybe use viral suppression then to show that, hey, because I was counting the people between ages of 16 and 30 with an HIV diagnosis, with a medical visit, but also with a mental health referral, let's see what the viral suppression rate looks like at that point. And I hope that this is clear, because for me, this is kind of like the crux of our presentation, right? We want to get this, sort of measurement right, and what it does and how you can use it, how you can include people and exclude people, but make sure that you are starting with the same baseline, counting the same baseline. It's relevant, it's addressing an issue that you want to address and measure so that you can provide the right service for the people in the clinic. So here's a different way of looking at it, right? Same thing. It was your HIV viral load suppression. You have the blue is all your patients. You have 2,000 patients at your clinic, all of them. But in your denominator, you only want the number of patients, regardless of age, with HIV that had at least one medical visit. Droop, that number drops to 1,000, just throwing out numbers, right? And then on your numerator, that's where you want the number of patients who are virally suppressed. And believe it or not, and I think you all know that 200 copies or less than used to be different across clinics. Some people had better machines that could count less than 200. Some people didn't. But we needed to get those that in the viral undetectable load have less than 200 copies, and we're not excluding anyone at this point. But this is your little formula. And at your clinic, you want to be able to align with this, right? You want to get all your patients, specifically those people that are eligible to receive your care. Obviously, they have to be HIV positive, and I'm guessing they have to be Ryan White eligible. And then which patients receive that specific care that you're trying to measure. So at this point, maybe it's not viral suppression. Maybe you just want to deal with mental health, and you can do that. I encourage always linking to viral suppression, but you want to follow this little pattern to be able to get the performance measure that you want to essentially measure and then provide a service on. So if you have any questions on this, we'll do it at the end. I'll skip through this, but to me, this is kind of the crux, especially this little diagram, especially thinking about your denominator, who are you including or excluding, and that even within the specific denominator that you have created, you might create a specific exclusion for the specific measure that you want to do. And that would be important. And once you have that, everybody has agreed to it, you monitor the same thing consistently over a period of time. So real quick, the PDSA cycle, like I said, you now have your measure. What is your goal? What are you trying to improve? How many more people are you trying to get housed? Better mental health care, better substance harm reduction support. What do you want to do, and what is your goal, and how do you think you can plan to do that? And put this little plan in place, the who, what, where, when. We carry this out. We say, you know what, let's start with 3 clients. Let's start with 5. Let's start with 4 and see where we can do. Document what's happened, observe it, and then begin looking at the data. It doesn't matter if it's only 4 people. Look at what has happened from what you decided to do about it. Reach the conclusions. Talk to the case manager. Talk to talk to the peer navigator. Talk to the data. Talk to the doctor. Reach conclusions, form opinions, compare your outcomes, even to hunches. Like, I have a hunch this person has a domestic violence situation, and we're just not going to be able to help them or get them out of. Summarize what has been learned, and then those 3 big A's. Are you going to adapt it? Are you going to say, okay, let's do this on a slightly larger scale, see what happens? Are we going to change something a little bit here, rather? Or are we going to adopt what we just did? Or are we going to abandon this? Didn't work. Let's try something else. And that's okay. And then you would start the next cycle. I said that already. For the model for improvement, improvement usually requires change. Not everything is an improvement. And then we have a little bit of time for any questions that might be in the chat or discussions that are just related to in thinking about, just this discussion. I mean, this is not the questions that we have to answer right now, but just sort of for reflection, does our community, our clinics, our planning bodies really use the thought or the effectiveness behind performance measures appropriately? Like, do we really use this? Like, for me, what has always bothered me is the people that are excluded. So it's great. We have a great viral suppression rate based on the fact that we counted only those people that had a medical visit. But what about those people that didn't have medical visits, and so on and so forth? Can they change, can we change our activities somehow? Does our community have, really established and productive partnership that meets the need of people, not just the viral suppression, but related to it, if we can use these measurements correctly?
Martha, we have a question in the chat. When working on our HIV quality plans, what is a good strategy for setting annual improvement goals for our core measures?
So that's a big question because I know that I have literally been with other coaches as we have coached clinics to come up with a quality improvement plan. But for me, I really believe a lot of things, even though we complain as a community that we focus too much on viral suppression. But I really believe it starts with those things that are impacting. It's kind of like a reverse strategy, right? What are those things that are not allowing us to reach our, 25%? If we're, it's at 95%, we're at 75%. So what is happening with that 20%? And I've been encouraged taking a peek at the excluded numbers. And for me, that's always a strategy. And you might find that it's a different reason. I mean, I've been to so many places now, South Carolina, Chicago, and it's always different issues. But one of the things that is very, very consistent for me, especially because of how HIV affects, minority populations, already disadvantaged populations, police populations. I mean, we have the same determinants that are impacting us. And so rather than just dealing with the medical, I encourage our plan to include some of these things that we know are impacting people. And it's hard, right? It's hard to deal with mental health. It's hard to deal with substance use. It's hard to deal with some of these big bucket things. But I say, little things can be done that it would amaze you at some of the solutions that can be found, especially when you coordinate and have private public partnerships. I've seen great things happen when you take a social determinant of health that is related to viral suppression and tackle it, and it really does improve some of your core measures. I think it's really about tackling the social determinants of health, the things that are making people I used to say that you find it hard to sleep. What is the thing that is really bothering the person? It's not their viral, it's not their medication anymore. What is it that's bothering them? And that's what you deal with. So a reverse strategy. Thank you for that question. It's a big question.
We have some other questions in the chat, which we will respond via email.
Yeah.
I just wanted to let you know that we are a little bit over. It's 5:03 already. Thank you everyone for coming and listen to this presentation. That was a great presentation. And next, our National Quality Improvement Technical Assistance Call is scheduled for June 27 at 4 p.m. and is on succession planning for your QI team. So I'll see you then. Goodbye,
Thank you
everyone.
so much all for being here.
Thanks for a great presentation, Martha.
Thank you.
Thank you.
Yeah, lots of people.